Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission: to provide medical professionals with the resources they need to learn from each other, and in doing so, to improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics, including the Physicians in Training Day in the Life podcast series. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org. Thank you for coming back for part 2 of our podcast, Ethical and Clinical Aspects of COVID-19. Where are we 1 year later? In part 2 of the podcast, we continue our conversation with Drs. Jason Wagner and Richard Holt as they discuss the effects of the COVID-19 pandemic as they look back on the past year. Dr. Holt, do you believe clinical outpatient care has been adversely affected or compromised by the pandemic?
Without a doubt. In my mind, but much of it was necessary and has been necessary. One of the problems I think has been that we don't have enough knowledge, particularly early on, to really know how to screen an outpatient to feel that they're relatively safe to be able to come into the exam room. The symptoms of, do you have a fever? And have you been, particularly in South Texas, have you been to Mexico lately, or Central America, or what have you? They don't always translate into an absolute causation question. And so when we try to determine who we can see in the clinic, we just haven't been able to do it risk-free, not only for them, but also for the other patients who would be coming to the clinic. And knowing that, a lot of patients have just been very averse to coming to see us in the clinic. There's no assurance that we can give them that they would be safe coming there. My practice is primarily outpatient and with indigent patients. Many of them are homeless. A lot of them come up from the penal systems in South Texas and along the border. And so in that regard, they're a little high risk. And we have to not only protect everybody in the clinic, but we have to protect the other patients coming in. And so there still is a little bit of concern about whether the patients we see are indeed going to put staff and other patients at risk or not. We do the best we can, but there's no 100% guarantee about that. Another problem in lieu of outpatient visits is, as Dr. Wagner alluded to, it's very difficult to have any real meaningful relationship with a patient, particularly a new patient, over the phone. And that really strains the ability to have a good patient-physician relationship, even though it's necessary sometimes to do that. For us, in most of our specialties, we really need to see and hear and feel them, lay our hands upon them, examine them. So, for instance, if I have to speak with a new patient that's referred for hoarseness, I can just get so much from the history, and a little bit more from listening to their voice, obviously, over the phone. But I can't feel their neck. I can't look at them with a scope. And so it really, I believe, does compromise my ability and others' abilities to serve that patient in the best way. Now, when a patient does get into the room, we have some limitation of interaction simply because we're all wearing masks. Many of my patients are lip readers because they have hearing loss, and they really can't can't see my lips or the residents or students' lips to aid their understanding of what we're saying. We have to try to speak up, and sometimes that works. But a mask is a muffler, and so we have some difficulty in the discourse. That's even amplified further by having translators who don't have to wear a mask. They may have difficulty listening to the patient when the patient has a mask, or we have a mask, obviously. We rely a lot as physicians in dealing with patients on facial expressions and body language. And a lot of that is lost with fear. Patient comes in really fearing about what risk they're at by coming actually to the clinic. So they're a little harder to read. We can't read facial expressions quite as well. And so that is a bit of a problem for us. But on the other hand, if we still have the same desire to develop a relationship, we can work around those things. And I think most of us have tried very hard, overcompensating perhaps, to develop a relationship with the patient. As Dr. Wagner said, we do the best we can and just hope that it turns out in the best interest of the patient.
It's interesting, a little bit of a personal note. I've contacted you because I am deaf in one ear, so it has certainly been a challenge, and I find myself leaning in even more with the masks. And my husband is very, very soft spoken, and he's a mumbler. My son is a mumbler, so we've had to sort of learn a new communication system, at least within our own house. Or I have to make John and Emerson shout and raise their voices, and when we're out together. And so it's been interesting for someone who has a partial hearing loss in something like this, and facial expressions, and trying to hear what everyone is saying. So I can relate to that particular aspect of it just a little bit. Dr. Wagner, what struggles have you seen individuals face after being discharged from the hospital? We've talked about outpatient care and ICU care. When they leave, what is happening, and what are those challenges like?
Great question. Before I touch that, I just want to highlight just this prior question and listening to Dr. Holt. The one thing a couple of things that I've noticed, the sort of untoward consequences of social distancing and mask wearing, is I've had a massive reduction in the number of folks calling in for antibiotics, or I have the flu, or common colds, et cetera, in these winter months. That's been incredibly mild with regard to respiratory transmitted diseases. And I have to wonder if that's because of the masks and the social distancing. I've seen one influenza case in the ICU this year, which is very large departure from normal. So back to your question, that what's striking about COVID is it seems to be unique in any way you look at. We know now that folks who survive the ICU for acute respiratory distress syndrome or septic shock are at risk for post-intensive care unit syndrome. We touched on this last time. Things like cognitive impairment, PTSD, depression, anxiety, neuromuscular weakness are common in individuals who endure a prolonged ICU stay. That is all true for patients who survive severe COVID-19. In terms of the prevalence of those comorbidities, it's, I would say, too soon to say. There's ongoing work figuring out whether or not these things are more common in folks that are discharged from the hospital after severe COVID, as say compared to septic shock. I'm interested to see how that plays itself out, but testimonially, which is the weakest amount of evidence to stand on, I feel like there are a whole bunch of people struggling, even those that have mild symptoms. So there's something called long haulers, which are folks that have COVID. They then test negative and they have unrelenting cough, shortness of breath, fatigue, cloudy head, things of this nature. And it's too soon to say how long that's going to last because we're still in the midst of it. But for many, it's been several months. Um, I have patients who have what looks like some chronic lung disease related to their initial hospitalization with COVID-19. And that doesn't tend to happen so much with influenza, for example, or ARDS. Usually the pulmonary function normalizes. And I have patients with abnormal CAT scans months after. With parenchymal or lung tissue abnormalities months after, more than just scarring. And so I think there's going to be a lot of learning, more understanding as time goes on in terms of the comorbidities that people will have to endure for after having had COVID-19. And of course, it's even more challenging to accurately measure the any long-standing effects or long hauler related issues in patients who don't access care. And so there are lots of us who've had COVID who maybe had a positive test but never sought care at an emergency room or hospital and may or may not be struggling. And so it's tough to accurately assess how common that is.
You mentioned that flu cases were down, and we're wondering if it's social distancing, mask wearing. That kind of brings me to another question. Are there proven lifestyle measures that have been proven to lower the risk of severe COVID-19? I know those are kind of simple steps, but are there other measures that can be taken that are going to help as we continue through this?
Well, I think that obviously mask wearing and social distancing is better than not mask wearing and ignoring social distancing. By how much, I don't know. I think we are now incredibly fortunate. I think it is an amazing scientific achievement to have vaccines available in the midst of a pandemic. And obviously, as a recipient of a vaccine, I feel better about it. And the data, it was one of the few vaccines that's actually studied versus placebo. And so I think there's a lot of good reason to be excited about the benefits that we'll receive as a society as more people get vaccinated. In terms of, are there any individual things that I could be doing on a daily basis to reduce my risk of COVID-19? That's probably one of the most common questions that my patients are asking me on my telemedicine visit for a chronic cough, for example. And sadly, I think the answer is I don't know. And with regard to with any scientific certainty, what I can, however, say is that I think it is impossible to ignore that certain comorbidities that are incredibly common in the United States are associated with more severe COVID-19 disease. And so anything related to the metabolic syndrome, type 2 diabetes, hypertension, hyperlipidemia, obesity, central adiposity, visceral fat, anything related to those things, there's increased risk associated with that. And that's irrespective of age. So the 30-year-olds that I'm meeting in the ICU are overwhelmingly obese compared to not. And so from a public health standpoint, should we as a society be looking at our lifestyle and asking ourselves some tough questions? I think COVID is providing us with an example to do that. Whether or not we're going to do that, I don't know. So, I think that would weight loss translate into a decreased severity of illness with regard to COVID-19? It's an interesting question. I don't know the answer. But I think a lot of those questions related to lifestyle are tough to answer, but are worth trying to answer. The other thing I'll just comment on would be, with over-the-counter things, there is a lot of emphasis on vitamins and supplementation. There was just a paper not too long ago looking at zinc. That was a negative study. There have been other things in the critical care world. Vitamin C tends to be controversial. Some people believe it does things, others do not. And then vitamin D, which I'm most interested in. I'm sort of remaining open-minded about this because, vitamin D we get from the sunlight. We're more often deficient than not, and it's an essential vitamin. So most of us, if we were to just randomly measure a 25 OHD level at the nearest grocery store on everyone who went in there, you'd have a lot of people that were deficient. And that is, most of us think about vitamin D with regard to strong bones, calcium, things of this nature, but it affects over, 900 genes. Many of them are involved in the immune system. And there is a lot of biologic plausibility to consider whether or not vitamin D deficiency is related to or translates into affecting your innate immunity and your adaptive immunity in ways that could lead to a worse outcome with regard to COVID. So Nature, which is a pretty prominent scientific journal, published a study that showed that individuals who were vitamin D deficient had much higher inflammatory cytokines than people who weren't. We have critical care study done on critically ill patients in general, show that were vitamin D deficient, that repleting them at the time of their critical illness doesn't seem to help. We have small studies looking at moderately severe people with vitamin D supplementation, and it doesn't seem to help, although many of the people that they supplemented weren't vitamin D deficient, so that's a flaw of the study. But I think it has not been answered yet. A couple things. Would aggressively screening for vitamin D deficiency and fixing it when you find it, would it result in less severe disease? I don't think we know the answer to that question, but there's a lot of good reason to think that it makes sense. And if we were to take a large group of folks presenting with severe COVID in the ICU and enrolled them to receive either placebo or vitamin D supplementation if they're vitamin D deficient, would that translate into improved outcomes? I'm interested in that because vitamin D affects the immune system. And all the things that we're finding that are at least associated with improved outcomes or being shown to improve outcomes in RCTs are things like steroids and now more recently tocilizumab. And so I think the jury's out there. I think there's little downside to replete something that should be there in the first place. There's no side effect of removing a deficiency, but whether or not it actually helps once the horse is out of the barn, so to speak, I don't know.
Interesting you touched on that because early in this, we thought my son had COVID and thankfully he had tested negative, but they did a bunch of testing and he was severely vitamin D deficient. And it has kind of led to some other testing to see what might be going on. And he's just 21 years old. But that was one of the first things they kind of, non-officially mentioned that
Right.
we thought it could be COVID. They said, well, you have a severe deficiency, vitamin D deficiency. So
I think in part it's evolutionarily we human beings were not too long ago out in the sun much more, wore less clothes while doing so, and so we're able to absorb a lot more vitamin D. Nowadays we're in cubicles and cars and houses, and applying sunscreen when we go outside. If we're light complected, if we have darker skin, we need more sunlight, especially if we're farther away from the equator, to get adequate vitamin D. And so I think there's lots of good reason for that today for just modern Americans are probably deficient for lots of different reasons.
As we look to wrap up this wonderful and very informative podcast, Dr. Holt, how well do you think the medical profession in the United States has responded to the pandemic? And do you have any examples you could share with us?
Well, yes, I think the profession has done, on the whole, pretty darn well. There were a few specialties, such as pulmonary critical care and infectious disease, who had had previous experience with things like the SARS outbreaks and so forth. And so they had a reasonably good handle on some of the challenges that were seen at first and how they might progress and how they might be dealt with. The rest of us, I think, started off pretty darn clueless with regard to our role and what we could do and how we could help everybody. Three good things at a minimum came out of all of this. I think most physicians now have a better appreciation for the importance of public health. Also, population-based medicine is in our forethoughts right now, as opposed to just individual care of patients. And then the real importance of evidence-based medicine in tackling something so widespread and important like this. Even though the evidence was pretty sparse at first, as it became apparent, and I will say that medical journals pretty much fast-tracked the publication of data that were coming in from academic institutions all around the world, according to their findings. And individuals who were looking at the clinical and basic science information tried to get it out as quickly as possible, and with a reasonable discussion about the impact or the potential impact of the information they were providing. I do believe the medical profession as a whole worked together very well to try to address some of the challenges. A real collegiality. It probably occurred across all of the specialties. I know in our specialty, we had protocols that were being developed and modified and shared all across the United States, and some sort of empirical at first, but as it became more refined and data were coming out of some clinical laboratories, we were able to upgrade our protocols for safety and effectiveness. And I was very impressed with how physicians acted not only together in their specialty, but across specialties as well to address these problems. We always have had good relationships with anesthesiology because we're all working in the same territory. But I think our discussions and patient care with anesthesia were never so good as they have been with this. I do have some concerns about how we're responding to the deficiency in medical education that occurred over the past year. For a good 6 months, residents and medical students had quite a limited exposure in some cases. Medical students in particular did not really get to see patients in person for months and months because they were being, quote, protected, close quote, by the medical schools so that they weren't exposed as future physicians to risking their lives in their careers. Because of the reduction in patient care in the outpatient setting, in the surgical suites and trauma units, such as in our specialty, our residents really lost a lot of hands-on experience over the past year. Can we make that up? I'm not sure whether we can or not, because we're still limited in the number of surgical procedures because of the various surges that have required moratoria on certain types of surgeries. Keeping the beds open for patients that Dr. Wagner is taking care of who are very, very sick. So I do worry about how medical education is going to be resumed to its full level of activity. Now you combine that with duty hour restrictions that were placed in 2003 and updated in 2013. And so you've got a cadre of residents all across the country who have been restricted to 80 hours for the most part a week. And then within that 80 hours, they have not been able to see and work with patients and operate and take care of them in a hands-on manner. I fear that there will be a gap in knowledge and experience in these folks that they're going to have to make up on their own when they're in practice. As an aside, I think there's also been an education gap in primary and secondary schools in the education of young kids. And Dr. Wagner is fully aware of that, having 4 children of his own. So all in all, I think the medical profession has stepped up. It's been a real learning curve with a steep slope to it. But we know a lot more now than we did a year ago or so when we were fortunate to be able to discuss our thoughts with you, Mrs. Price. And I think the future looks a little brighter because of what we have experienced and what we have learned.
Dr. Wagner, are there any thoughts you would like to add to that as we?
I agree wholeheartedly. I think that it's been a challenge, but I've it's that person in the arena, so to speak, and I watched a lot of folks in the arena over the last several months, from environmental services to respiratory therapy to nursing to pharmacy to physicians, showing up every day with a lot of uncertainty about safety and all sorts of things, and did their best. And so that was always gratifying and made it easier for me to show up too, just to see the goodness in people. So it's nice to see people battle tested and watch people exceed beyond their own expectations. And I think that's something that has been quite common. I think people are exhausted. But I think when this is over and we're on the other side of it, I think there's going to be a whole bunch of people that are proud of themselves. So at least that's what I tell myself. So.
Well, thank you, both of you, so much for what you're doing and for your colleagues. I mean, you're risking your life every day to help get us to the other side, as you just said. And we cannot thank you enough for what you're doing and for your service and your dedication in something that we've never seen. So I'd like to thank you personally both for that.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.